This program is brought to you by Emory University.
Good morning, everybody. Welcome to Friday Morning Fellows Conference, Journal Club edition. We did have we normally, for those of you that know, normally have two presenters. We had a last minute sort of thing that came up with one of our presenters this morning, so we're just going to have one article today. Luckily, the other presenter for today, she's going to be able to present her article in like 3 weeks. We had an opening in the schedule, so you will get to hear that one as well. So we just have one article today from one of our third-year fellows, Nida Waheed. She's becoming a Journal Club veteran at this point. She did her undergraduate and medical school studies at the University of North Carolina, and got her MPH at Johns Hopkins before going to University of Florida for her internal medicine residency and chief residency. And as you can see, we're going to be talking about a novel treatment for reducing Lp(a) levels. So Nida, take it away.
Okay, sounds good. Thank you, Dr. Williams, and good morning. So as he mentioned, today I wanted to talk about a cardiology trial that was actually presented at the AHA at the last meeting. And it's about a small interfering RNA called olpasiran and its effect on Lp(a). So I have no financial disclosures, and I wanted to start by introducing what we currently know about Lp(a). So it's a glycoprotein that essentially has two major protein components, which are ApoB100 and apolipoprotein(a). So apo(a) is strongly associated with atherosclerotic cardiovascular disease, and Lp(a) has been associated with increased risks for atherosclerosis, thrombosis, and aortic valve calcification. The Lp(a) concentration is heterogeneous, but to a major extent controlled by genetics. So you can see some of the factors here, but about 70 to maybe even greater than 90% of Lp(a) levels are genetically determined. And Lp(a) is considered a risk-enhancing factor for ASCVD according to the 2018 AHA-ACC cholesterol guidelines. So there is some epidemiological data to support a causal role for elevated Lp(a) and the development of ASCVD. So there was a meta-analysis of about 36 studies that included more than 126,000 participants. And it showed that the risk of coronary heart disease was about 13% higher for every one standard deviation in increase in Lp(a) levels. Now, the largest study to date examining the risk of ASCVD and the association with Lp(a) levels was done using the UK Biobank. So this included more than 460,000 individuals, and the risk of ASCVD was about 11% higher for each increment of 50 nanomoles per liter. There is data from ERIC, MESA, and MASALA cohorts that link higher Lp(a) levels to increase ASCVD risk as well, but the methods used to measure Lp(a) were variable, making it hard to kind of compare some of that data. So how do you define what a high level is? It can be variable. So the 2018 AHA-ACC cholesterol guidelines define a level somewhere greater than 125 nanomoles per liter as being high. But it's important to keep in mind that what's defined as high can actually vary because there are multiple factors, including different assays that are used, as well as differences in the median Lp(a) levels, which we'll see in a second based on ancestry. So these factors have made it difficult to establish a universal threshold for clinical use. So in the UK Biobank, the Lp(a) levels differed across several self-reported racial and ethnic groups. So here you can see the overall median of Lp(a) amongst the population was about 20 nanomoles per liter. But Black individuals and South Asians had higher median Lp(a) levels than white or Chinese individuals. So I won't go into all of our lipid-lowering therapies, but I wanted to mention 3 major ones that we use in clinic and what their effects are currently known to be on Lp(a). So the first one is obviously statins. So there was a meta-analysis that was published in The Lancet a few years ago and included 7 randomized placebo-controlled trials. The analysis included more than 29,000 participants and with repeated Lp(a) measurements. So even though the initiation of statin therapy reduced LDL cholesterol by about 40%, there was no significant change in Lp(a). So that kind of brings us to the next agent, which is ezetimibe. There was a meta-analysis to suggest that using this either alone or in combination with a statin does not affect plasma Lp(a) levels. And in terms of PCSK9 inhibitors, the Fourier trial was published also in the New England Journal. And so in this trial, Lp(a) was measured in more than 25,000 patients. Essentially was a trial that used evolocumab versus placebo in patients with established ASCVD. The median baseline Lp(a) concentration was about 37, and at 48 weeks, there was a significantly reduced Lp(a) by median of about a reduction in the median by about 26.9%. So, it's interesting data to kind of see. And so that kind of brings us to, but the other point I just wanted to briefly mention is that even though there was a reduction, it's currently thought that we need a very large reduction in Lp(a) levels to see kind of the benefit in clinical outcomes. So that kind of brings us to the discussion on olpasiran, which is a small interfering RNA that is administered subcutaneously. The way that it works is that it targets the hepatocyte. The siRNA, so the interfering RNA, forms an RNA complex called the RNA-induced silencing complex, also called RISK or RISK. The sequence of the guide strand of the siRNA directs the complex to bind to the mRNA transcript of the Lp(a) gene. The complex essentially functions as a pair of molecular scissors that cleaves the mRNA, causing it to degrade and stop translation. And so the Lp(a) gene transcribes and ultimately leads to the translation of apo(a), which, as I mentioned before, is one of the components of the Lp(a) particle. So the complex can then target more copies of the same mRNA, and thus the effects are catalytic and allows for a prolonged duration of the effect. So essentially, olpasiran disrupts the expression of the Lp(a) gene, degrades apo(a) mRNA, and thereby prevents the assembly of the Lp(a) particle in the hepatocyte. There was a phase 1 trial that was done in Japan that had 27 participants. And the study randomized 27 participants, like I said, to receive a single dose of 3 milligrams, 9 milligrams, 75 milligrams, or 225 milligrams dose of olpasiran. If you look at the graph, you can see that olpasiran reduced Lp(a) concentrations in a dose-dependent manner, with doses of 9 milligrams or higher, reducing the circulating Lp(a) concentration by more than 90%, with an effect that persisted for about 3 to 6 months. So now that brings us to the current trial that I want to talk about today, about the effects of olpasiran, and it's in a phase 2 clinical trial. So the objective of this trial was to evaluate the efficacy and safety of repeated administrations, as well as several different doses of olpasiran in patients with established ASCVD. The inclusion criteria were any adult between the ages of 18 to 80 years old with a serum Lp(a) concentration greater than 150 nanomoles per liter at the time of screening, plus a history of ASCVD. including coronary heart disease, PAD, SCVA. A couple of the main exclusion criteria were severe renal dysfunction, defined as a GFR less than 30, as well as a history of or clinical evidence of active liver disease. The primary outcome was the percent change in Lp(a) concentration from baseline to week 36. There were some secondary outcomes as well. These included a percent change from baseline in Lp(a) concentrations at week 48 to see how long the effects would last. The percent change from baseline LDL concentrations at both week 36 and week 48, and the percent change from baseline in lipoprotein B concentrations, again at week 36 and 48. So in terms of the study design, it was a multi-center, randomized, double-blind, placebo-controlled, and dose-finding trial of olpasiran at 34 participating sites in 7 countries. The trial was designed by the sponsor, which was Amgen, in collaboration with the TIMI study group. And there were 218 patients that were enrolled. Again, they had established cardiovascular disease and Lp(a) concentration greater than 150 nanomoles per liter. You can see here that this is kind of the timeline and how they gave the doses. There were essentially 5 groups, one group that received the placebo and 4 different olpasiran groups. One received 10 milligrams, one 75 milligrams. Another group received 225 milligrams every 12 weeks of the study duration. And the other group got 225 milligrams every 24 weeks. So you can see here kind of the times and time points where they received olpasiran or placebo. And the patients were followed for an extended safety follow-up period without further administration of olpasiran or the placebo for a minimum of about 24 weeks after this point. So this is a little bit of a crammed slide, but essentially I just wanted to highlight that basically a minimum of 48 patients were needed per group to have at least 90% power to detect a relative treatment difference of 25% between the olpasiran groups and the placebo group for the primary endpoint analysis. It was intention to treat, and essentially, each group had about 50 plus patients, but there's very little dropout, very few adverse events, which we'll highlight a little later. And 1 death total in the study, but and 1 patient was in the placebo arm. So there was also a safety analysis, and adverse events and safety laboratory values were assessed by a central laboratory every 12 weeks during the treatment period. So that kind of brings us to our the patient characteristics. As you can see, the majority of patients enrolled were white men, about 60 years of age or older. There were about 30% of enrolled patients were women. This is continuation of the patient characteristics. And here you can see that most people enrolled had CAD, a vast majority, followed by PAD and CVA, like as I mentioned before. The other thing I wanted to highlight was that most of these patients were on either one or multiple lipid-lowering agents. So a vast majority were on statin therapies. Almost 50% of patients in each group were on Zetia or ezetimibe. And what I thought was interesting was that about 1/5 to 1/4 of patients in each group were on a PCSK9 inhibitor, which again, we know decreases Lp(a) levels as well. In terms of the median measurement of Lp(a) levels in the patient population prior to receiving any therapy, you can see that the medians are actually much higher than the 150 nanomoles per liter threshold that the study used to enroll. And another interesting point is that you can see that the LDL cholesterol levels were fairly well controlled in each group prior to receiving olpasiran. So here you can see the percent change in Lp(a) concentrations at week 36. So there was about a 66.9% reduction in Lp(a) concentrations for the 10 milligram group. It was 93.8% different in the 75 milligram group, which is in green. There was a 97.5% reduction in the group that received 225 milligrams every 12 weeks, which is the blue line, and then a 96.9% reduction in those receiving 225 milligrams every 24 weeks. And you can see that there is a slight uptrend or slight attenuation that occurs with the 225 milligram group every 24 weeks. So you can see kind of after the 16-week mark that there's slightly less difference, and then they receive another dose at the 24 week time point, and then again the levels drop, but then it goes back up by the time the follow-up period around 40 weeks and 40 to 48 weeks. So here is the distribution of percent change in Lp(a) concentrations at week 36. Each bar on these graphs represent an individual patient. And you can see that in the 75 milligram groups or higher, there is at least a 95% reduction in Lp(a) levels at week 36. So we kind of described the percent change in Lp(a) levels, but you can also see that there's a percent change and a decrease in LDL cholesterol levels as well in these patients. And you can kind of see the numbers here, as well as a percent change, although less so, in the apolipoprotein B concentrations in these groups, as you can see here. So there's also safety data. So overall, olpasiran was well tolerated. The most common olpasiran-related adverse event was injection site pain. The injection site reactions led to the discontinuation of olpasiran in 3 patients. None of the events were considered by the investigators to be severe, and all of the affected patients had some kind of pre-existing dermatologic condition. And this was followed by hypersensitivity reactions, but again, those were also kind of located around the injection sites. So in conclusion, olpasiran treatment markedly reduced the concentrations of Lp(a) in a dose-dependent manner, and it appears to be safe. At the higher doses, olpasiran therapy reduced the Lp(a) concentrations by more than 95% as compared to this placebo. And nearly all the patients who received olpasiran achieved Lp(a) concentration that was less than 125 nanomoles per liter. The pharmacodynamic effects of olpasiran were maintained through the administration intervals when the drug was administered every 12 weeks. There were some limitations. So the treatment period was limited to 48 weeks, which included 12 weeks of safety follow-up after the last administered dose at week 36. And although an extended safety follow-up phase was implemented as part of the current trial, a larger and longer trial is necessary for the evaluation of the long-term efficacy and safety of the drug. All trial patients did have elevated baseline Lp(a) concentrations, but it remains unknown whether similar pharmacodynamic effects of olpasiran would be observed in patients with lower baseline concentrations. And then finally, as I mentioned, the majority of patients who were enrolled were white, and there's a need for greater representation of Black and Hispanic or Latino patients, as there are higher concentrations of Lp(a) levels that have been described in these populations, which I mentioned briefly in the background. So there, in terms of future directions, it's it's very interesting. There's already a phase 3 clinical trial that is currently recruiting to answer some of the questions we've raised earlier about the clinical impact of reducing Lp(a). The primary objective of this study is to compare the effects of olpasiran treatment to placebo on the risk for coronary heart disease death, MI, and urgent coronary vascularization in participants with ASCVD and elevated Lp(a) levels. And I think the estimated enrollment target is 6,000 participants with a follow-up period of about 4 years. There's also an outcomes study that using lipoprotein apheresis to remove Lp(a) and other ApoB-containing lipoproteins. And there are also other therapies that are being studied, and they're in various phases of clinical trials right now. So we might be hearing more about Lp(a) therapies in the future. And I think that's most of it. Thank you so much. I'm happy to answer any questions or hear your comments or thoughts about this trial, or yeah, thank you.
Thank you, Nida. I didn't see anything in the article about cost. You know, I'm sure they're not going to advertise that, but do we know what's known about the potential cost of this drug?
That's a really good question. As far as I know, it's really expensive, but I don't have a number for you. But since it's so new, I do.
Yeah. I'm sure it's probably not publicly available. I don't know if it's been alluded to anywhere at this point, but
yeah, I didn't see anything, but I guess we'll find out. Obviously, we know PCSK9 inhibitors are expensive as well, so I'm assuming it's going to be a little bit more, maybe, or a little or a lot more than that.
Well, I guess my question would be, you know, assuming it is expensive, and assuming, you know, it's obviously very efficacious at its stated goal of reducing Lp(a) levels. What do you see as like the potential, you know, target audience for this drug if it does, you know, if it does end up being safe and working and becoming FDA approved?
Yeah, no, I think obviously initially I think there'll need to be more patients enrolled in the trials, but as we see, you know, hopefully once we see the clinical outcomes trial, I think there'll be a big push for having this readily available. So I kind of see it being as, you know, after you've kind of have maybe had a PCSK9 inhibitor and it's not, you know, it hasn't gotten adequate Lp(a) concentration reductions, I think that's when it will initially probably be used. But honestly, the data is it looks very promising. So I think it'll eventually be that, you know, like we check lipid levels, we'll be checking Lp(a), which is currently recommended even by the CDC to get your Lp(a) levels checked. And then we'll be treating that kind of separately, probably from the regular lipid profile that we currently try to treat.
Nina, this is Man, really good. I may have missed it, but how do we have any idea how potent this is at reducing clinical outcomes? It looks very potent at reducing Lp(a). And to that end, you know, how big is the trial? Because I think that will inform us. The bigger the trial means the less efficacious it is, probably. So just, do you have any idea how big the upcoming phase 3 is?
Yeah, so the upcoming phase 3 is also going to be enrolling at the 34 sites that they were enrolling for this trial, 7 different countries. And the target, I think, enrollment that I had mentioned was 6,000, I believe. Yes. So I think the target was 6,000 participants. And then the follow-up, as I mentioned, was for 4 years. So we'll hopefully get more safety data and more a lot more data about clinical outcomes. There are some, you know, studies that have been published that hint towards there being meaningful clinical outcomes differences with reducing Lp(a) levels. But I think, you know, kind of like I mentioned before, the thought is that there might have to be a significant drop in Lp(a) concentrations, kind of like what this drug did, which was almost, you know, greater than 95% reduction in Lp(a) levels. That's kind of what they're thinking would hopefully translate into some kind of clinically meaningful difference. But yeah, that's the upcoming trial, and they're currently, I think, already enrolled patients.
That's really just that's very interesting. Generally, I'd be curious to see what the trial shows, but generally speaking, the bigger the trial, the less efficacious the medicine. So if it takes thousands and thousands and thousands of patients to eke out a p-value, that tells you that the number needed to treat is very high, and that you're probably not affecting, clinical outcomes, as well. But obviously that depends on the population you are studying. But again, we'll have to see what the trial shows.
Yes, and I think right now, they're enrolling patients with very high Lp(a) concentration to hopefully answer this question a little better. Because if you see a drop there and you see a meaningful difference, then hopefully they can apply that to patients with lower levels. And like you said, we'll see what that number needed to treat is.
Nida, Stan Sherman, it looked like you showed that the LDL would drop in patients too. Did they pre-specify in the clinical trial how much the LDL is dropping besides the Lp(a) is dropping, and pre-specify that?
Oh, I think they, looked at it as a secondary outcome, but I don't recall anything about the mechanism in terms of how that happens. But it seemed like the LDL level concentrations were, got reduced. I think a fair bit, but the apolipoprotein B level was about, reduced percentage by about 10%. So we don't routinely, measure that, but again, that's something else to kind of look into.
Yeah, if we're going to explain what happens and say this is because we decrease Lp(a), it could be because we're decreasing LDL some more.
Yeah, and that's a good point. It's but I think, as I had kind of shown in the patient characteristics, like the LDL levels were pretty low to begin with. They were somewhere between 60 and 70, which is, usually our goals for somebody with established coronary disease. So reducing it a little bit more than that, whether pushing it from 60 to 50 is going to make that much of a clinical difference. I'm not too sure. I'd probably think that it was more about the Lp(a) concentration at that point. But you bring up a really good point.
Nida, I missed the beginning of your talk because of technical issues, but did you talk about niacin in this context? Because the niacin is a very potent reducer of Lp(a), and yet in the clinical trials that have been done with it, it was largely had no effect on outcomes. So if you said something about that, I apologize, but I just wanted to raise that issue with you.
Yeah, no, I actually did not bring that up. So thank you for mentioning that, Dr. Thames. I mentioned, three other ones: the statins, Zetia, and PCSK9 inhibitors. Just to kind of keep the talk a little brief. But because niacin was also, hasn't been shown in the trials to really reduce Lp(a) levels, I didn't mention it. So I appreciate you bringing that up.
No, in fact, I thought it doesn't reduce Lp(a). Niacin is one of the few oral agents that does that, and it does it significantly, and yet it has no impact on outcomes. Oh,
sorry. Yes, I meant like in terms of outcomes that we've seen. What the little bit that I had read about it. Yeah. Yes. There's no difference, but I think the absolute, I can't remember off the top of my head, but the amount that it reduces Lp(a) is not as significant as Alpaceran. But I'll have to look into that data a little bit more. Thanks, Dr. Thames, for bringing it up.
Yeah, I'm not surprised it's not as potent, but what is surprising, and I raised this issue with Anurag Mehta, who has a great interest in this area. And he's just as baffled as I am about this.
Oh, interesting. Yeah, I don't know if anybody who, one of the preventive cardiologists is on the line and can speak a little bit more to that point, but I'll look into it as well.
Dr. Dickert has his hand up.
Hey, Dr. Dickert.
Hey, I'm unmuted now. So I was just going to say that just from a sort of trial design perspective, Mon's question about size is important, but I think it's also important to recognize that we've had lots of drugs. You look at take Paradigm to look at sacubitril valsartan. That's a trial of 8,000 people, and it has certainly what I think most of us would consider to be a meaningful difference in outcomes, even if it's not totally overwhelming. The other thing that's really important with regard to trial design in studies like this is you're looking at a drug that really we're trying to reduce outcomes over a much longer period of time, but you have a choice between time of follow-up and number of patients. So what they're doing is you have a lot of people over a relatively speaking short period of time, right? 4 years of follow-up is
Right.
functionally a pretty short time for a preventive drug. So there's the size of a trial, is sort of one piece of information, but it has to be looked at in context of both the expected effect as well as the sort of duration. And I think, there's nothing that I think that's all not surprising about the size and time that they would expect for a drug like this. The big thing I think is that they're doing a study that's going to show at least hard outcomes and not just for reasons everybody else has alluded to. It would be a real problem if they were just looking at surrogate markers.
Yeah, no, I think that the trial conclusion, whatever it is, will be really interesting, but I appreciate you bringing up those points because you're right, like the median follow-up time period isn't something like 8 to 10 years. They do need to do it in a more dual window. Yeah.
Yeah, because it seems like their target audience is secondary prevention and some patients with controlled LDL, but high, right, as you mentioned, high LP little a. So you would not a group you'd expect an outrageously high event rate, So again,
especially not in a four-year time frame.
Correct, not in a 4-year time frame. All right, well, everybody gets a free 30 minutes to start their day a little early. Thank you, everybody, for tuning in. Thank you to Dr. Waheed, and we'll see everybody next Friday.
The preceding program is copyrighted by Emory University.